Good morning. This is March 25, Wednesday, and the time is 10:47 a.m. The Insurance Committee of the Tennessee House of Representatives of the 114th General Assembly is now in session. Members, please remember to sign in. Mr. Clerk, please take a roll or open the roll. Okay. Mr. Clerk, please take the roll.
Mr. Chairman, you have 14 members present. You have a quorum.
Thank you. Members, do we have any personal orders? Seeing none, we will move on with our calendar for today. Item 1 is House Bill 0829 by Chairman Hicks. Chairman Hicks, we have a motion and a second. You're recognized on the bill. I see Amendment 4503.
That's correct.
Members, can I have a motion and a second? We do. All those in favor of attaching Amendment 4503 to House Bill 0829, please say aye. Aye. Opposed? The amendment goes on the bill. Please explain your amended bill to us.
All right, Chairman, members, good morning. House Bill 829, this is the annual hospital assessment bill. It simply continues the hospital coverage assessment passed each year to fund a major part of our TennCare program.
Members, do you have any questions? Seeing none, questions been called. All those in favor of House Bill 0829, vote aye. Opposed, no. Mr. Clerk, please take the roll or the vote.
Mr. Chairman, you have 13 ayes, 0 nays.
Thank you. House Bill 0829 moves on to Finance, Ways and Means. Familiar grounds.
Yes, sir. Thank you, Chairman. Thank you, members. Feel pretty good.
Chairman Hicks also has House Bill 0728. We have a motion and a second. There is no amendment. Chairman Hicks, explain House Bill 0728 to us.
All right. Thank you, Chairman and members. House Bill 728, this simply extends the annual nursing home assessment for the fiscal year 25-26. So this is the annual nursing home assessment.
Members, do we have any questions? Seeing none, the question's been called. All those in favor of House Bill 0728, please vote yes. Opposed, no. Mr. Clerk, please count the vote.
Mr. Chairman, you have 14 ayes, 0 nays.
Thank you. House Bill 0728 also moves on to Finance, Ways and Means.
Thank you, Chairman and Committee. Thank you.
Item 3, House Bill 0870 by Chair Lady Rudder. We have a motion and a second. There she comes, all right. Madam Chair Lady, on House Bill 0870, we have a motion and a second. I don't see any amendments, so kindly explain your bill to us.
Thank you, Mr. Chairman. House Bill 870 is a follow-up attempt to fix unfair programs related to corporate entities which restrict the ability of patients to apply patient assistance payments to their deductibles and out-of-pocket expenses. We stopped these schemes with previous legislation, but they keep coming back with new ways to avoid the law. This program can include AFPs, which is Alternative Funding Programs. But you can call these schemes maximizers, optimizers, accumulators, AFPs, or whatever. It doesn't matter. Every time we stop one, they just rename to confuse the patient. The bottom line is this: my bill is simple. It says no matter what you call the program, no entity should be permitted to engage in any activity which prohibits, or restricts patients' assistance funds from being applied to the patient's deductible and out-of-pocket expenses. Section 2 of this bill, Section 2A of this bill, fixes an IRS issue with our previous legislation regarding accumulators and health savings accounts. Section 2D prohibits any entity from using patient assistance programs in an inappropriate way that would restrict that patient from being able to apply those funds to deductibles or out-of-pocket expenses. And Mr. Chairman, that is my bill, and I'll stand ready for questions.
Thank you. Members, you have any questions? Chairman Speaker, you're recognized.
Thank you, Mr. Chairman. And so just talking about your bill, this is in regards to couponing. Is that correct?
Correct.
You're recognized.
Thank you, Mr. Chairman. The question I have for you is, the couponing right now can apply to the employers. You want this to apply to the employees' copays, is that correct?
To the patient's copay, yes.
You're recognized.
Does your bill still allow the employers to take that benefit also?
Chairman Rowe.
It only applies to patients taking that deductible.
Chairman Speaker.
Would your bill prohibit employers who are currently able to take this deductible?
Chair Lady Rowe.
Well, there's a part. Sorry, go ahead.
I think it does. This bill prohibits employers because there is a fund set aside for people that don't have access to with the specialty drugs. That's the point of this fund. The patient-assisted programs. So this is for people with no other choice. And so I wouldn't think that the employer would have a benefit. This benefit is for patients.
Chairman Speaker.
Thank you.
All right. Well, thank you. Kindly elaborate a little bit on how it interacts with the health savings accounts.
I don't know how it would interact with health savings accounts.
Okay. Would you be able to help? Do we have any help from any of the members in answering that questions? Well, legal says that they may be able to help. So we will go out of session, and legal services, you're recognized.
Levin Middleton, Office of Legal Services. So from my understanding, under subsection A of the bill, there was a law that was previously passed dealing with calculation of an enrollee's contribution to applicable cost sharing requirements. There are contribution requirements and limits under federal law. And my understanding of the new language being added in subsection A is that if the law that we previously passed and those calculations would result in ineligibility under section 223 of the Federal Internal Revenue Code, then the requirement for that cost saving calculation only applies for health savings account qualified high deductible health plans with respect to the deductible of the plan after the enrollee has satisfied the minimum deductible, except for preventative care services. My understanding is that this is trying to fix an interaction that was occurring based on how the law was previously passed.
Thank you. Members, do we have any questions for legal? I do. Now, you said that this language is being added. When will that be added? Would that be in the form of a new amendment coming?
No, that language is currently under subsection A of section 2. The first sentence of subsection A, from my understanding, is current law, and then everything after it would be new.
Could you kindly read that?
Sure. If under federal law, application of this requirement would result in health savings account ineligibility under section 223 of the Federal Internal Revenue Code, then this requirement applies for health savings account qualified high deductible health plans with respect to the deductible of such a plan after the enrollee has satisfied the minimum deductible under section 223 of the Federal Internal Revenue Code, except for items or services that are preventative care pursuant to section 223 subdivision C2C of the Federal Internal Revenue Code, in which case the requirements of this subsection A apply regardless of whether such minimum deductible has been satisfied.
Members, did that clarify everything? Thank you. Thank you. Thank you for reading the language. It's rather a little complicated. I hope we are not imposing upon you, but can you simplify it a little bit or in common person's language?
Just a moment to try to.
Well, we'll give you a moment, if that's all it takes.
So from my understanding, the current statute requires including all amounts paid or on behalf of an enrollee when calculating their out-of-pocket contributions. And the new language would require that if doing so would make their health savings account ineligible, then the existing requirement will only apply to health savings account qualified high deductible plans once the enrollee satisfies the minimum out-of-pocket amount.
Thank you. Thank you. I think that does make sense. Members, do we have any questions for legal? Okay. Oh, we will go back into session. Chairman Spicky, you're recognized.
Thank you, Mr. Chairman. So for clarifying, if and when we pass this bill, this copay now, or I'm sorry, this coupon will now be able to be taken by the patient, therefore allowing them to meet their deductible in a quicker manner. Would this allow the employer to take a higher copay then because they're reaching that number quicker, and allow the employer to get a benefit of possibly a lower premium plan to increase the amount of benefits offered to the employee?
Chair,
Yes.
I think so.
Thank you.
Okay.
Thank you.
Members, any other questions? Well, thank you for. Chairman Hale, you're recognized.
Chair Lady Rudder, I just wanted to make sure, and it kind of comes off of Chairman Sapicki's comment there. So in other words, if I spent $25,000 for medicine prescription, then that would go towards my deductible, where currently it's not, right?
Chair Lady Rudder.
If through the through this plan, through these funds, if you spent that out-of-pocket money, yes, sir, it would go towards your deductible.
Okay, thank you. Just wanted that clarification. Thank you so much.
We do have 2 citizens who have signed up to testify. Without objection, we'll go out of session. Invite Mr. Patrick Nichols. Mr. Nichols, your mic is on. Do identify yourself and who you are with, and you have 3 minutes.
All right, thank you. Good morning. My name is Patrick Nichols. I'm a specialty pharmacist here in Nashville, and thank you for the time. I appreciate the time given to allow me to give some data from my practice demonstrating the negative impact alternative funding programs have on patient care and tell the patient stories of real-life Tennesseans that are being forced to use these deceptive, complex, and difficult programs to access life-saving and life-altering medications. To briefly summarize how AFPs function, they convince employers to use their services, often promoted as patient advocates, to try to curb their pharmacy spending for their employees. Rather than cover medications through a traditional insurance benefit, AFPs seek to obtain medication through alternative means, such as manufacturer financial assistance programs meant for uninsured patients or through international pharmacies. AFPs take a cut of the savings from the employers, often charging 25% or more of the purported savings, while the AFP searches for alternative medication access options. Patients are left without treatment and are often very confused as to how they are supposed to get their medication. Though AFPs are not yet very common, we are concerned about their recent growth. My health system documented over 100 patients enrolled in AFPs in 2024. The data we have collected on these patients shows that the average time it takes for a patient enrolled in an AFP to get medication from the time their doctor decides to treat them is almost 2 months, compared to patients who don't have, all patients who don't have AFPs is usually 2 to 5 days. 20% of our patients enrolled in AFPs experienced a gap in therapy at some point during their treatment. An additional 36% of those patients required a free sample from their provider to prevent a gap in therapy. 30% of the identified AFP patients were required to receive their medication from an international pharmacy, most commonly Canada. Another 30% were forced to receive their medication from the manufacturer's patient assistance program that is designed for patients who do not have insurance. As others have said, this reduces the funds available for those who truly need it due to being uninsured or having a financial hardship. While these numbers show the potential harm AFPs have just from delaying necessary care for debilitating and life-altering conditions, they do not tell the stories of the individual patients. I'm going to tell a few stories, but before I do, I want to stress they sound absurd, they sound grandiose, but they are true, documented stories that have happened to your constituents and my patients, and without action, they will increasingly continue to happen. First patient story I tell involves a working male in his mid-30s with insurance that he pays for through his employer being treated for metastatic cancer. He was on an effective cancer treatment for 6 months before his employer chose to use an AFP for pharmacy benefits. After being required to enroll in the AFP in order for him to continue the medication that he was prescribed for his cancer, he had to obtain a passport, which he did not have at the time of treatment. He was forced to have a telehealth visit with an international provider that was not previously involved in his care. And then finally, he was able to receive the medication from an unknown pharmacy in Europe. The next patient I'll describe is another Tennessean with employer-sponsored insurance that, of course, requires her to pay a premium for coverage. She was receiving her medication for Crohn's disease from a Canadian pharmacy as mandated by her plan. The prescriber recommended increasing the dosing frequency of her medication due to her severe disease and ongoing symptoms. The authorization for this change in dose was denied with no option for appeal. She was not eligible for the manufacturer's patient assistance program because she has insurance. Ultimately, a full 8 months later, she was approved to receive the medication at the necessary dose. But this happened to coincide with a postal worker strike in Canada that required her to find a different pharmacy in America. And then when the postal worker strike ended in Canada, she had to transfer her prescription back.
Mr. Nichols, we've allowed you more time
Okay,
than planned.
thank you, thank you. Can I
but-
make one closing statement, please, Mr. Chairman?
Sure.
Thank you. As you can see from the data I've quoted and the patient stories, AFPs may claim to offer alternative coverage for patient specialty drugs, but they are actually harming patients by causing delays in treatment or pushing patients to use a potentially unsafe and unfamiliar international pharmacy. The individuals working at these international pharmacies may be great pharmacists, but many of these specialty medications require disease state monitoring and specific temperature controls during shipping.
Thank you, Mr.
Yeah,
Nichols.
thank you for your time. Thank you.
Members, do we have any questions for Mr. Nichols? Chairman Speaker?
Thank you, Mr. Nichols. I wasn't clear. Could you finish up that statement you were making?
Yeah, absolutely. All right. So I quoted the data. I told the patient stories, and they're used to force these international pharmacies. But the problem is most of these drugs do require disease state monitoring and even specific temperature controls during shipping. So I do question that those can be maintained during international delivery. Additionally, it is unlikely that a pharmacist in a different country would have access to the patient's medical record to be able to screen for drug utilization, such as drug interactions, to know if the medication is safe for the patient. And then finally, the final point I want to make is these plans are forcing patients to use international pharmacies that aren't planned by the same rules as our pharmacists and pharmacies here in Tennessee are planned by, because we're licensed by the state to provide medication and medication services, and these pharmacies are obviously not, because they're international. So that's the last point I'll make, and I appreciate your time.
Thank you.
And we'll answer any
Chairman
questions. Yeah.
Speaker,
So
do you have a follow-up?
I do have a follow-up.
Yeah.
So on a follow-up, that if this bill passes, it'll be a benefit to the patient and it'll also be a benefit possibly to the employer. Is that correct?
Yes.
Thank you.
Members, any other questions? Thank you, Mr. Nichols. We appreciate you coming.
Thank you for your
Thank
time
you.
and extra time.
Secondly, we have Mr. Brian Duval. Mr. Duval, thank you for coming. Your mic is on. Please identify yourself and tell us who you're with.
Thank you. My name is Brian Duval. I'm a Master of Public Health student at Vanderbilt University, where I study health policy. I live with severe hemophilia A, and hemophilia is a rare bleeding disorder where my blood will not clot without medication. These medications are incredibly effective and have allowed me to live a normal life. However, they are incredibly expensive. So because of this, considerations of cost and access are incredibly important to people like me. I'm here to talk about a new scheme, and Patrick touched on this previously, known as an Alternative Funding Program, or AFP. These AFPs aim to generate savings for employers at the expense of limited access to drugs and burdensome outcomes for patients like me. An AFP is a third-party vendor who works with an employer-sponsored insurance plan to try to save money on costly specialty medications. However, these savings are generated by strategically placing barriers in between patients and the prescriptions we need to survive. The AFP's business model is all about restricting access to certain drugs. They work alongside the health plan to design an incredibly narrow formulary or automatically deny all prior authorizations for specialty drugs. After a patient in need of one of these drugs has had their prescription denied, they are given two options: pay a 100% coinsurance or sign up with the AFP, signing over power of attorney. Once the patient is signed up, AFPs seek alternative means to source a drug, and most often they redirect the patient to a charitable patient assistance program offered by a drug manufacturer, which offers a life-saving drug for free as a safety net for patients without insurance. Patient assistance programs are not designed to be a permanent solution and often have income limits or other requirements that may make someone ineligible. In other cases, they'll import a drug from overseas, which Patrick touched on previously, but this can be very dangerous. If they're successful, the AFP is compensated by the employer in the form of a flat fee or a percentage of the costs avoided. However, this process can take as long as 60 days and patients may be left without any options. And this is unacceptable for someone with hemophilia. I cannot go a week without my medication, let alone 2 months. AFPs brazenly call this work advocacy, but it's important to remember an AFP profits each time they are able to successfully enroll a patient in an assistance program and restrict our medication from being covered in the first place. AFPs are here to light our houses on fire and be the first one there with a hose. It's vital that we preserve charitable programs for those who truly need it, not force average folks with a steady income and means to pay for health insurance to receive charity care. Should we make everyone save money on groceries by forcing them to try the food bank first? I don't think so. Overall, AFPs must be banned, and HB 870 is a step in the right direction for my community. Thank you.
Thank you. Thank you for your testimony. Members, do we have any questions? Representative Hakeem, you're recognized.
Thank you, Mr. Chairman, and thank you both for making your presentations. I guess I'm asking myself, there's no entity that regulates the actions of the AFP, to the point where, it's essentially threatening the lives of individuals. There's no such entity in federal government that you're aware of.
I believe there are entities that do have the capability of restricting these programs. However, they have not taken action. So action at the state level is still important.
Okay. Thank you very much, Mr. Chairman, and thank you.
Well, thank you. Your testimony was meaningful, and thank you for coming. Chairman Sparks?
I just assumed some other members would ask some questions. How old are you, son?
23.
23 years old.
Yes,
So
sir.
how long have you been dealing with this?
With hemophilia?
Yeah.
My entire life.
entire
I was
life.
diagnosed at birth.
Well, you probably know more about this issue than all these lawmakers up here. Do you agree?
Perhaps, yeah.
I bet you do. I was sharing with somebody earlier, my stepdad was a state investigator for the Board of Pharmacy for many years, started the first Walgreens in Green Hills in 1958. And I wondered how we've become so convoluted, confused, chaotic in this industry with the PBMs. It's a super confusing issue. They may not admit it. They're all confused too. Okay. And I appreciate the lawmakers' passion for helping folks. Our drug, I said this last week, I think the week before, our drug costs are higher than any nation on the face of the earth. Why is that? What would you answer? What's your answer on that?
Yeah, there's a lot of things about the American healthcare system that are unique. When it comes to the price of the drugs, that's not really my wheelhouse. To share a little bit more about my drug specifically, it costs probably about $500,000 per year to treat somebody like me. But hemophilia is something that once had a life expectancy of only 15 to 20 years. Now it's something that's evolved into a chronic condition you can live with access to medication.
Wow.
If not for these meds, I would not be here today, but because of them, I'm able to live a happy and healthy life. So my biggest concern really is the access. When it does come to drug pricing, there are much larger conversations to be held about, why this medication is so expensive in the first place. But anything that places barriers in between me and my access to medication is something that's always going to be a concern to me. So, going back to this bill, this would be a very important step in the right direction to maintaining access.
Yes, sir. Thank you, sir.
Thank you.
Thank you. I think it's meaningful for us to realize that the cost of sustaining your medication, and aren't you glad to be an American?
Very proud.
And Chairman Sparks, I'd like to clarify what you mean drug costs are higher than any other nation. You mean in the developed world, because we supplement by paying these higher costs and financing this research, we supplement medications that are given at much less cost in the poorer nations and the developing nations. Seeing nobody disputing me today, thank you for coming. Without objection, we'll go back into session. Chairlady Rudder, you're recognized. Members, do we have any questions for Madam Chairlady? Chairlady Helton Haynes, you're recognized.
Thank you, Mr. Chairman. We passed legislation a couple of years ago that required patient assistance and coupons to apply toward the patient's deductibles and out-of-pocket maximums. Does your program apply patient assistance and coupons to the deductible and out-of-pocket costs of the patient?
You're recognized.
Yes, it does.
Thank you. I will be supporting the bill, and I urge everyone to vote for it as well. Thank you.
Well, thank you. That was a meaningful question.
I don't want to be the only one making these comments. hoping my colleagues here will, and this is a big issue. It's a big issue. Everybody should chime in on this. Just for the record, I mean, we need a Department of Government Efficiency. When it comes, see, I'm losing people. When it comes to medical cost, you know, the free market, this is not a political, I mean, it shouldn't be a political issue.
Chairman
We know we got
Sparks.
a problem. We know we got a problem with drug cost. We need to dig deeper on this issue, and we don't do that as a body. I'm just saying. Thank you,
Chairman
Chairman.
Sparks, your points are correct, but we do need to stay on the bill. Question's been called. It's about time. With our members, we are ready to vote on House Bill 0870. I think Mr. Clerk has opened the vote. Members, all those in favor vote yes, opposed no. Please count the vote.
Mr. Chairman, you have 17 ayes, zero nays.
Thank you. House Bill 0870 moves on to calendar and rules. Thank you.
Mr. Chairman and committee.
Item number 4 on our agenda is House Bill 0372. Its roll 1 week. Item number 5, House Bill 0858. Representative Alexander, you're recognized. We have
Thank-
a motion and a second.
Thank you, Chairman, and thank you, committee.
And which amendment do you want to run?
006, no, excuse me, I'm sorry. I want to, yes, I'm giving you the right one. 006264.
Members do have a motion and a second. We have a motion and a second for amendment 006264 to be attached to House Bill 858. All those in favor say aye. Opposed? The amendment goes on the bill. Kindly explain your amended bill to us.
Okay. Step therapy is known as a fail first, is an insurance policy that requires patients to try and fail and on insurer preferred medications before their prescribed treatment is covered. This process forces cancer patients to take medications that may be less effective or even harmful before they can access the treatment their provider has determined is best. For patients with cancer, especially those with metastatic disease, this delay has devastating consequences. Waiting days or even weeks for insurance approval means losing valuable time when every moment matters. In some cases, the side effects from insurer-mandated medications can further weaken a patient's health, making effective treatment even harder to tolerate. In Tennessee, the commercial insurance market is the only one that requires step therapy for cancer patients. Neither TennCare nor Medicare imposes this requirement. The amendment before you eliminates step therapy for patients with metastatic cancer, ensuring that they receive the right treatment at the right time. I have seen very close friends this year to die. Lots of times they were waiting as many as 10 days for the insurer to approve of medication that their oncologist had prescribed for them. With a metastatic cancer, they don't have 10 days. And in giving them drugs that aren't the best drug is very hard on their body and harder for them to tolerate the medicine that they need the most to get to the drug. With our biomedical abilities anymore, doctors know they have the right drug for the right cancer. Please, I beg you, to do this for the patients in this state that are suffering with metastatic cancer.
Thank you. Members, do we have any questions? Thank you. Questions been called, but I would like to add that the trauma of being denied something at the end of life is probably more meaningful or more devastating than the medication alone. Well, thank you for bringing this. We are ready to vote. Mr. Clerk, please open the vote. And members, all those in favor, vote yes. Opposed, no. Mr. Clerk, please count the vote.
Mr. Chairman, you have 18 ayes, 0 nays.
House Bill 0858 moves on to calendar and rules. Thank you.
Thank you, Chairman. Thank you, committee.
Item number 6 on our agenda is House Bill 0867 by Chairman Hicks. We have a motion and a second. Chairman Hicks, I see an amendment.
Thank you, Mr. Chairman. Yes, sir. 006003.
We have a motion and a second to attach Amendment 6003 to House Bill 0867. All those in favor, please say aye. Opposed? The amendment goes on the bill. Kindly explain your amended bill to us.
Thank you, Mr. Chairman. All the amendment does is creates a pilot program that covers no more than 300 pregnant postpartum women. The program will conclude 2 years after the date of implementation, and the program will cost no more than $600,000. That's what the amendment does. This legislation establishes a pilot program for remote patient monitoring, RPM, of maternal hypertension and maternal diabetes in pregnant and postpartum women. TennCare will administer the pilot program and implement the program in as many counties as possible across the state and ensure participation of at least 300 eligible women. Women with pre-existing or gestational hypertension and diabetes require daily monitoring to best manage their conditions while pregnant. With remote patient monitoring, vitals like blood pressure, weight, and glucose are monitored 24/7 by a team of clinicians to track and catch problems before they become emergencies. RPM improves outcomes, access to care, adherence, and lowers overall healthcare cost. Through a maternal RPM pilot, Tennessee can lead the nation in leveraging innovative solutions to expand access to critical maternal care while improving outcomes. Thank you, Mr. Chairman. I'll be happy to answer any questions.
Thank you. Representative Hakeem, you're recognized.
Thank you, Mr. Chairman. Chairman Hicks, would this be, I guess I'm going to use the term sampling from across the state, or would this be concentrated in West, Middle, or East? How are these people selected?
Chairman Hicks.
Thank you, Mr. Chairman. This will be required all the way across the state, and especially in our rural areas. That's the goal, is to really hit the rural areas and all the way across the state.
Representative Hakeem.
Thank you, Mr. Chairman. I'm sure you're aware and mindful that the items you spoke of dealing with hypertension and things of that nature, inner cities have that problem too.
Mm-hmm.
I'm not saying overlook the rural communities, but let's be mindful that it's a statewide issue. Thank you, sir.
Chairman Hicks, you have a response?
Yeah, thank you, Mr. Chairman. And I'm sure that it'll be in inner cities as well. It'll be spread all over the state.
Thank you.
Mm-hmm.
I think it's great use of current technology by remote monitoring. Members, any other questions? Seeing none, Mr. Clerk, please open the vote. All those in favor vote yes, opposed no. Mr. Clerk, please count the vote.
Mr. Chairman, you have 18 ayes, 0 nays.
Thank you. House Bill 0867 moves on to Government Operations Committee.
Thank you, Chairman.
Thank you.
Thank you, committee.
Item 7 on our calendar is House Bill 0782 by Representative Martin. We have a motion and a second. I don't see any amendments. Representative Martin, welcome back. Good that you are in good health and shape. Kindly explain House Bill 0782 to us.
Well, Mr. Chairman, I feel extremely fortunate to be in the Health Committee, and so thank you for that. PACE stands for a program of all-inclusive care for the elderly, and a PACE program allows frail older adults to safely remain living in the community. PACE provides all services at one location and allows those being served to continue to live in their homes. PACE programs are fully capitated, and the program is responsible for all cost of health care and long-term supported services for frail older adults who are eligible for nursing facility level care. PACE is a unique program that is enjoying significant growth across the country. Tennessee currently supports one PACE program in my county, in Hamilton County, in Chattanooga. The program is very successful, but it is statutorily restricted to only a certain number of enrollees. This legislation requires the Teen Care Bureau to authorize one additional program in either West Tennessee or Middle Tennessee. And this legislation also expands the current Chattanooga program to allow participants to come from counties surrounding Hamilton County in the state of Tennessee. PACE programs are very popular with family caregivers. They reduce hospital admission rates significantly. They improve a quality of life for both the person receiving the service and the caregiver. And Tennessee seniors outside of Hamilton County area deserve the opportunity to have this option for care. With that, Mr. Chairman, I'll be happy to answer any questions, and I would appreciate a favorable recommendation.
Thank you, Mr. Representative. We've heard about the PACE program. How long has it been functioning in Chattanooga?
I believe that it's been around a quarter of a century.
Okay. And by the cost, how does it compare to the Choices program?
Well, Mr. Chairman, I think it's one of those programs that perhaps the focus needs to be upon the quality of care. Does it cost a little more? Perhaps. But it's the quality of care of being able to take your mother or your father where they can continue to live with you and yet get the services at one of these daily PACE centers. And I had the privilege of touring the one in Chattanooga a few months ago, and oh, was I impressed with the programming, with the care that they had, the clinic that they had to make sure that folks were getting their medicines if someone had an event that they could be taken care of. And so is it the cheapest way to go? Perhaps not, but is it a better quality of life for those that get the opportunity to be in the PACE? Absolutely. And sometimes, many times quality should trump cost.
Surely in healthcare, everybody deserves a Cadillac. Sure. This is funded by CMS. Is that true?
If you say it is, Mr. Chairman, I believe you.
It seems
You've never lied to me ever before.
Members, do you have any questions? Chairman Speaker?
For you, Mr. Chairman, did you say everybody deserves a Cadillac? Is that true?
In healthcare.
Thank you. Is that made in the United States, I hope?
Well.
My best friend.
The question's been called. All those, Mr. Clerk, please open the vote. All those in favor, please vote yes. Opposed, no. Mr. Clerk, count the vote.
Mr. Chairman, you have 17 ayes, 0 nays.
Thank you.
Thank you,
House
Mr. Chairman.
Bill
and committee.
0782 moves on to GovOps. Item number 8, House Bill 0385 is off notice. Item 9, House Bill 0411 by Chair Lady Lynn. We have a motion and a second. Madam Chair Lady, you have an amendment. Oh,
I do not.
was it your preference to roll this
Oh, I'm
one week?
sorry. This is the one that we will roll. Yes.
Okay, all right.
Thank you, Mr. Chairman.
Well, we have good people who remind us. So this is without objection, roll 1 week. Your next
Thank
bill, House Bill 1158. We have a motion and a second. And this one does not have an amendment. Kindly explain House Bill 1158 to the committee.
Thank you, Mr. Chairman. House Bill 1158 was brought to me by the Tennessee Disability Coalition on behalf of families participating in the state's Katie Beckett program. This bill asks TennCare to take necessary steps to offer a health reimbursement account option for families enrolled in Katie Beckett Part A in order to utilize the program's home and community-based services funds. The Katie Beckett program was actually started by Ronald Reagan in 1982, and it was started because, and the program is named after a 3-year-old girl in Iowa who was gravely ill. Her parents had health insurance, but their health insurance would not pay for all of the care that the child needed. So the child had to live in a hospital in order to receive the care she needed. And it was pointed out at the time and since then, oftentimes parents gave up their jobs so they could get on Medicaid because their health insurance would not pay for all of the care that their severely and gravely ill child needed. And because basically the parents earned too much money, that's why they couldn't get on Medicaid otherwise. But Katie Beckett programs allow parents of children with profound disabilities or chronic health conditions to enroll their child in Medicaid to cover the extensive costs of their care, regardless of the parent's income. Currently in Tennessee, our program has 300 slots and 239 children are enrolled in the program. And they do pay a premium to receive about $15,000 in services. Tennessee's Katie Beckett program is broken up into 2 parts. There's Part A and Part B. Part B is a Medicaid diversion program that offers flexible funds for home and community-based services like home health care, medical equipment, and therapies. Those funds in Part B are administered through a health reimbursement account or HRA, and that's what we're asking TennCare to do for Part A. This flexible arrangement allows parents to make effective and efficient choices about how to support their child with a disability. Part A is different. It enrolls children fully in TennCare Medicaid and offers home and community-based services funds as well. But these funds must be spent through the purchasing process of the managed care organization that enrolls the child. The use of these home and community-based funds is a cumbersome and inefficient process for these families. And we do have a parent here who is here to testify. Of the $15,000 in home and community-based funds allotted to each child in Part A, families are only able to use an average of about $2,800 to support their child's healthcare needs, according to TennCare's own numbers. This bill is simply asking TennCare to take necessary steps to ensure that parents of children with profound disabilities enrolled in the state's Katie Beckett Part A program have easier access to the home and community-based services funds through an HRA account, just like they would if they were enrolled in Part B. And Mr. Chairman, I do have two people here, if the committee would allow them to testify. Jeff Strand from the Tennessee Disability Coalition and Trevor Anima, a parent who is representing himself, but he has served on the board. So he has a lot of experience talking with parents who utilize Part A.
Thank you. Without objection, we'll go out of session. And Mr. Strand, you're number one on the list. Your mic is on. Kindly identify yourself and tell us who you're with.
Is that all right if Trevor goes first?
Certainly.
Okay, thank you.
Thank you, Jeff. Good morning.
Okay, go ahead and identify yourself and tell us who you're with.
Thank you, Chairman. Thank you, representatives. My name is Trevor Anima. I am a proud dad and a full-time caregiver for my 7-year-old daughter, Stella. My daughter was born with a number of complex medical needs, and as a result of her primary diagnosis, she is a wheelchair user. So I'm here today to, go ahead.
Just to let you know, you have 3 minutes.
Thank you kindly. I'll be very brief since time is short. I'm here today to speak about my family's experience within the Katie Beckett program. We are fortunate to have been part of the program since its inception. We know what it's like to have been without the help of the waiver program, and it's difficult to articulate where we would be without it. I cannot stress enough how important this program is to our family and to everybody that's part of this community. And it's with that I'm happy to say it's been absolutely life-changing. I mean, it really is a fantastic program. We would really be lost without it. It has provided opportunities for my daughter that have brought me to tears multiple times. It has been a lifeline for our family and for every family that is a part of the program. And having been part of the advisory council, I've gotten a lot of direct feedback to support all of those things. Now, anything is not without its challenges. Katie Beckett is no different than that. I believe anything good takes effort to be great. I believe anything that is great takes constant effort to stay great. And it's in that spirit that I bring forth some of those challenges. And as you've already been informed, I guess let me speak to this. So we've been fortunate to have been part of Part B and now part of Part A. So my daughter desperately needs the Medicaid coverage, which is why we're in Part A. But with that, we have not been able to use the full allotted funds every year for home and community-based services because, for lack of better terminology, there's too much bureaucratic red tape for us to be able to access those funds that you have allotted to us. And I just don't think that was the original intent when you passed this bill. And so with that, that is why a lot of families have requested a flexible spending account within the Part A portion, because it does put the decision-making in the hands of the people who know best, which are the parents. We really, truly know what our kids need. And there are so many safeguards in place to make sure that the families can't take advantage of the system, which we welcome. It's an opportunity for us as families to show you just how resourceful we are and how far we stretch the dollars that you do give us to give our children the maximum benefit possible, because we care about our kids more than anything. And that is exactly why I'm here today. And it's so in that spirit, I wanted to inform you that because of the safeguards in place against the parents, we're being taken advantage of by the vendors. We're being price gouged. I mean, 1,000% price gouged because we have no other choice. Whereas with Part B, in this specific example, because this happened to my family, I would have had the ability to spend $200 and do the work myself, then spend $2,000 for the one vendor that came back with a quote for us. We didn't feel that would have been a good use of our money, and we want to be good stewards with what we've been given. So it was in that instance that we actually turned down a necessary project for our family, again, making it difficult to use the full allotment of funds. Thank you for my time.
Well, thank you. Thank you. Members, do we have any questions for Mr. Anima? Okay. Mr. Strand, you're on. 3 minutes.
Thank you. Good morning. My name is Jeff Strand. I'm the Director of Public Policy for the Tennessee Disability Coalition. Thank you, Trevor, for telling your story. When the General Assembly passed Katie Beckett 6 years ago, Stella is who they had in mind when we looked at what this program would do for people. And you all in the General Assembly trusted TennCare to design the program, to be a capable administrator of Part A, and to fulfill your legislative intent when you all voted this program into existence. And I'm here, I guess, to be sort of the bad guy to make a case for funding this. TennCare has not lived up to that charge. The fiscal note attached to this bill reveals some very concerning details about TennCare's design and implementation of the program. First, we're concerned that TennCare must ask for additional state funding to facilitate the use of these HCBS funds by families enrolled in Part A. TennCare in the fiscal note argues that it cannot pay the full extent of this HCBS funding benefit if everybody were to use the full allotment. The General Assembly allots $25 million a year to administer Part A. That's a lot of money. TennCare established the size of Part A program and set it at 300 enrollees. There have never been 300 children enrolled in this program, so year over year, we are concerned that that money has disappeared that could be used to pay for a program like this. TennCare established the size of the HCBS funding benefit and set it at $15,000 per person. Their own fiscal note says that Part A families are only able to use about $2,700 of it, so where's the other $1,300 or $1,200 going? For TennCare to claim poor in this case is simply, for us, beyond the pale, and it's a violation of the trust that the General Assembly and the community put into TennCare. And as you heard Trevor describe in his testimony, the use of those funds is so wrapped up in bureaucratic red tape that one must come to the conclusion that this is generously a pretty profound design flaw or a pretty profound implementation flaw, and one that TennCare is unwilling to fix even through their own technical advisory group, which Trevor sits on. TennCare designed the program in such a way that their MCA partners are in charge of administering the benefit, and those MCOs are responsible for contracting with appropriate vendors. As their contract written by TennCare states, those vendors chosen by the MCOs require the use of their own favored products rather than products the family knows works. Those vendors upcharge the cost of their favored products, in some cases by 1,000%. And those chosen vendors are, quite honestly, ripping off the state and ripping off these families. Ultimately, what matters and what mattered when you passed Katie Beckett in 2019 is the families enrolled in this program. So let's empower those families. They know far better than TennCare or the MCOs how to best utilize their funds in the most efficient and effective way possible to meet their children's needs. By giving them the option to use a health reimbursement account, just like Part B of the program, they can accomplish this. So I'll stop there. Thank you for your time. Happy to answer any questions.
Thank you. Members, we have questions for Mr. Strand. Chairman Lafferty, you're recognized.
Thank you, Mr. Chairman. I just wanted to ask you if you would follow up. You've made a pretty strong accusation about some companies taking advantage of the families, taking advantage of the program, raising prices 1,000%. Have you got clear examples of that? I mean, this is something that would need to be looked into.
Sure. I can give you an example we hear often. And so that $2,700 that we hear, or TennCare writes in their fiscal note that they spend per enrollee, sounds a lot like what we hear from families utilizing their assistive technology benefit. So within that $15,000 as administered by the MCOs, there are caps on the individual items that you can spend on. So if you're getting assistive technology, the cap is $3,000 per year. And what families are telling us is that they can pretty much only afford an iPad using that, and the cost is about $2,700. From what we check when we go to look at Amazon or the Apple Store, we see that that same iPad's about $1,000. Now, I can't tell you who exactly that vendor company is, but this is something we hear consistently. If Trevor's still allowed to talk, I'm sure he could talk about his home modification project that has similar upcharging.
Thank you. Could we recognize the other
Sure,
speaker?
Mr. Anima, you're recognized.
Yes, sir. Happy to speak to that. So my wife, who is brilliant, since I'm on record, anytime you have an opportunity, I also like to go on record and say I love my daughter and would do anything for her, which is why I'm here today. When I told her I had a chance to speak with you, she said, "Dad, we have to advocate." So I'm here on behalf of Stella to do that. And I'm happy to report to you that my brilliant wife does keep track in a spreadsheet of every vendor that we use, every purchase that we make through the program, and tracks how much we're being upcharged. We can tell you safely that it's a minimum 40% on any purchase. And this is for things that we find ourselves on Amazon and turn in to be approved through letters of medical necessity. My daughter has a 50-person care team. So when they make rounds, there's a lot of people that need to check in and say, hey, is this medically necessary? And when they say yes, we get approved. But we've already done all of the legwork as the consumer to find the product we need, how to adapt it to our child in the best way possible, and then also where to procure the item. So now now we're charged a procurement fee. I don't know if you've heard that one yet, but it's awesome every time I see it on paper. So minimum, we're being upcharged 40%. And in some cases, like the minor home modification, 1,000%. That specifically was, let me speak to that and I'll try to be brief. I submitted 17 projects for minor home modification to make my house accessible to a wheelchair user. And it took me 4 years to find a house that would be an acceptable candidate to even do that. So we'd already met everybody more than halfway in our attempt to make this happen for my daughter. And in doing that, we were denied for all but two. One that was approved was to widen doorways so that my daughter could get into the bathroom just to be able to wash her hands because we only have one roll under sink in the house. Where we ran into issue is under minor home modification, we're not allowed to do any work to the floors, which I'm sure you can imagine is a challenge to any wheelchair user or anybody that uses any assistive walking devices, gait trainers, etc. So in that spirit, we were trying to get the doorway widened with the one project that was approved, and we had one vendor return a quote on it. When they came out, they saw our floors were in disrepair. They were not able to widen the doorway, so we went to Plan C. Plan C was, let's widen the door's opening by putting extendable hinges on it. Those hinges we found on Amazon for less than $20 per hinge. So we had about $200 in raw material costs. We got a quote back of over $2,000. Again, this is work I could have done myself, same day.
Who was that quote from?
I would have to check to give you an
Okay.
answer on that.
Right. And which is the board that you serve on?
I was part of the Katie Beckett Advisory Board.
Okay.
So it is our job to compile the real user feedback from the families within the program to determine how we could make it better. Our only hope, after several years of not having a feedback loop with TennCare, was to provide a feedback loop where we could give them our feedback and hopefully hear back. Yes, sir. I'm sorry.
Do they interact with TennCare?
They do, but we are not able to, unfortunately. So it feels like
So
we're just
being-
kind of putting it out there for them to hear.
Being on the board, were you not able to interact and relate these stories?
We were able to relay our stories, but we weren't able to get any real-time feedback about whether or not they were implementing any change based on the feedback given.
Okay.
And we've given several examples of how we could easily fix some of these issues.
Let's be brief here.
I'm sorry.
Tight
Yes,
for
sir.
time.
Thank you.
Chairman Leffert.
And just, yes, thank you for sharing that. And it's an unfortunate, well, very sad story to hear on your behalf, but also very unfortunate that it's not uncommon throughout governments.
That's correct.
It's a very dozy feeling thing that's going on here and something that needs to be looked at. Thank you.
Thank you.
Okay. Chairman Parkinson, you were.
Thank you, Mr. Chair. I received that. I wanted to, Mr. Strand, were you finished with your presentation? You seem like you had a little bit more that you wanted to let us know about.
Just in the name of concision, I was good. Thank you, though.
Okay, thank you. And thank you for your testimony and your love for your daughter and your brilliant wife. Your wife is brilliant.
Yes, sir.
Okay, thank you.
Thank you. Representative Hakeem, you're recognized.
Thank you, Mr. Chairman. I hope that my history, my track record, my love for people comes through, but I feel like I'm between a rock and a hard place. And what I mean by that is that I believe we, the state, have put, I believe, $250 million in a vault, I'm going to say, for the Katie Beckett program. And I hear what you're saying about the $2,700 and then $1,300. I wouldn't say it was misappropriated, but it's not. Is it not being used appropriately, or what?
It's our understanding that it's not being used at all, that it goes back to either the vault or some other pot of money.
Okay,
You're recognized.
thank you. And I would also say that dealing with TennCare, quite frankly, I feel like when I say they're stretched thin, there's so much to be done, and there's so many dollars to deal with. And I'm looking at that pot, and maybe I'm looking at it wrong, but that $250 million as to what changes might be able to be made there. But I have entities in my own community dealing with children with disabilities, Orange Grove Center. And, you know, they're being asked to do much more today themselves than what the state can do. And I guess what I'm trying to get at is that would we be taking monies from another program to fix this item? Now, it feels like, to me, what you're describing to me is that either that, I don't know if the state needs to file a lawsuit or just what needs to happen in regards to what the vendors are doing. I mean, it's just not, it's not sitting well with me, not comprehending well with me that you take, I'm gonna say $20 for door hinges and then talk about $2,000 for, I guess, dealing with the opening in the door. So I don't know if I shouldn't say throwing more money at it. It seems like process and procedure, there's something else we can do to tighten this up. Thank you, Mr. Chairman.
Thank you. Go ahead, Mr. Strand. You wanted to respond?
Yeah, and I 100% understand that. It's our hope that they could accommodate the full extent of benefits within the $25 million they get every year. Their fiscal note says that they can't, and that's frustrating and concerning for us. But we agree that there's a lot of work out there that needs to be done for the disability community, and we would hope that any improvement to this process through an HRA or any other suggestion from the technical advisory group doesn't negatively impact those other needs.
By they, do you mean TennCare?
Yes. Sorry, I'm thinking where I said that. Yeah.
Well, I think a number of things have been said, and I think they're more, it should be of interest to TennCare. Maybe we can, in an organized way, lay certain things out. And we had TennCare come for a hearing and testimony or program, and we can follow up with them if there is enough organization and a list of things that we are concerned about. I'm sure TennCare cares to listen from us. Members, Chairman Sparks, you recognize.
Just want to say I loved your testimony. You mentioned something about enemy or something. Did you say don't let perfect be the enemy of good? You said something about enemy or something. I thought I'd heard. Caught my attention.
Yeah, I don't recall that.
Yeah. Anyways, that's Voltaire. That just what got my attention when you said that.
Fair
Let me
enough.
ask you. Sounds like you need a Department of Government Efficiency to learn to do more with less. So this was marked up. How much again? How much?
I'm sorry.
How much was some of this marked up again?
So anywhere from 40% to 1,000%. And
Jesus.
I mean, it seems like the sky's the limit. And really, it's not you all that are being taken advantage of. It's the family. You've already allocated the funds. You've allotted them to the families. It's we who are either not able to access them, or we're being price gouged, which feels wasteful to the people trying to be a good steward with what you've allotted us.
Yes.
You know, we don't want to throw good money after bad. We want to use those dollars wisely and be good stewards.
Yes, sir. Anyway, thank you, sir.
Thank you.
Chairman Representative Parkinson, you recognize.
Thank you, Mr. Chair. And again, thank you. You don't need a Department of Government Efficiency. They would have fired the employees, so you wouldn't actually get the phone answered. But
let's
stay. But I did want to ask. You mentioned $15,000 per family, right? And go ahead. And families are only able to access $2,700.
Yes, sir. The program is designed so there are 15,000 what are supposed to be flexible funds to fill in those gaps, the extra costs of having a disability or a child with a disability. And according to TennCare's fiscal note, or the fiscal note with the information TennCare provided, it's an average of $2,674 per person. It's about 18% of the benefit.
Well, thank you. I think we need to move on.
Okay, I'm good, Mr. Chair. Thank you.
All right. Without objection, we will go back into session. Thank you for your testimony, gentlemen. Okay. Chair Lillian, thank you for bringing this matter to the committee. Do we have any questions for Chair Lillian? I have Chairman Spicky.
Thank you. I 100% support this bill. However, there's been information brought to this committee that I think needs further discussion. And the one thing I'm concerned about is if we pass your bill right now, it's going to be very difficult to bring that discussion to the forefront in front of this committee with TennCare. Would you consider rolling this bill a week? And then, Mr. Chairman, we asked TennCare to come in next week and testify on this so we can ask them direct questions in correlation to what the testimony has been.
We could do it that way, or we could just ask the stakeholder parties to put certain things together and have a list of matters to be addressed and have a testimony from TennCare. Or but you're suggesting you do it within the confines of this bill.
I think, sorry, Mr. Chairman.
Okay.
I think there's been concerns made by multiple members of this committee about the possible waste that our citizens that we work for are trying to save money for the people of Tennessee. And because of the system and bureaucracy we have in place, there is profiteering taking place right now. And I would love to have this conversation on this bill that's been brought to our attention with testimony by the representative to give it its due time in this committee. But it's up to Chair-Lady Lynn.
Chair-Lady Lynn, you have an opinion in the sense that we could do it within the confines of this bill, but I don't know with the time for the session running short, this bill is going to Finance, Ways and Means. Yes, if those committees will be open, and then, or whether to have a separate, we could have a separate hearing with the testimony from TennCare. Representative Hakeem, you have an opinion?
It's up to y'all.
Thank you, Mr. Chairman. I concur with Representative Sapicki.
Okay.
I don't think we're going to be closing it by next week. Is it feasible or possible for us to have representatives from TennCare here to answer questions? I mean, that's what we're about.
I think that is a valuable second, and we will go ahead and, without objection, roll this bill to next week. Thank you for your patience.
Thank you, Mr. Chairman.
Okay. Let's see, what time? 59. Okay. Considering that we are out of time, the remaining of the calendar is rolled to next week. Thank you. Do I have a motion to adjourn? Without objection, we are adjourned.